right, a very good morning to everyone. It gives me great pleasure to introduce my colleague, Dr. Julian Wong. He's a psychiatrist and medical lecturer at the Department of Psychological Medicine. He earned his MBBS from Monash University and later completed his Masters of Psychological Medicine here at University Malaya. In addition to teaching and research, his clinical interests encompass a broad range of psychiatric comorbidities with a particular focus on consultation liaison psychiatry, community-based mental health services, and psychotherapy. Currently, he's a member of the Consultation Liaison Psychiatry Services here, as well as the Community Mental Health Services in University Malaya. He's also a certified CBT therapist for insomnia. With no further ado, I'd like to welcome Dr. Julian. Thank you.
Good morning, everyone. Thank you, Dr. Manveen, for the very kind introduction. Before I start, allow me to just share my slides. We're just going to switch a bit of gears after learning about gut microbiota, about microbiomes, and then all the way to the mind right now. So there's always somewhat of a gut-brain connection going on. And we're going to talk a little bit about psychiatry today. The topic we chose today for discussion would be psychotherapy in depression and looking beyond just pharmacotherapeutics or pharmacology treatment. The reason why we choose this, as you can see in the background, there's a typical psychologist couch in the background to just illustrate that sometimes treatment of psychiatric illnesses goes beyond just medications and chemical management. We should also look into the psychological and also the social issues that affects our patients. So without further ado, I hope today's talk will be informative to everyone. And I'm just going to start to peel behind a very thin layer superficially on what exactly psychotherapy entails in the treatment of depression. It itself can be a very lengthy discussion that we can go on and about it and might need a separate complete lecture. So without further ado, let's just jump into the first slide. So this is a bit of background. As we all know, depression is one of the major mental illnesses affecting the population internationally. So it affects approximately 200 million people, 280 million people worldwide. This is as of 2022 from WHO statistics. We could be talking about closer to 300 million right now. And depression is a major contributor to disability, mortality, as well as healthcare costs, be it in the private or public healthcare settings. So in countries where there are universal healthcare planning or benefits for the people, this is a big contributor towards the expenditure. It is also the second leading cause of years for a patient to have lived with disability, according to the same WHO statistics in 2022, meaning that people with depression tends to be more debilitated and also be unable to be as productive as they should be, according to their age group, compared to their peers who do not suffer from this condition. And unfortunately, despite its disease burden worldwide, the medications and treatment that we have right now that are primarily approved are still mainly medications such as antidepressants and also psychotherapy. So it is a wide-ranging subject that we want to dive into. So let's just look at what exactly psychotherapy can offer in depression treatment today. So as to carry on from the preamble, the depressive burden worldwide causes increased mortality and morbidity as we know it. There are billions of dollars lost in productivity and healthcare costs as of Koenig et al. And his colleagues' publication in 2020. So significant economic as well as healthcare burden going on there. And no one is spared. It's actually a very fair illness. So depression does not pick and choose. Depression affects basically people of all age group and demographics. If the onset is at a young age, then that individual will have a longer lifespan of disability and struggling that he or she cannot perform to his or her potential. And it also does not discriminate in demographics. So it doesn't mean that if you live in a certain region of the world, you're less predisposed to having depression. It's actually equally fair worldwide. So how do we manage depression in general? So in psychiatry, we talk about the biopsychosocial and recently the spiritual model of treatment. So we go for encompassing holistic care for our patients. And what's widely publicized and what we discuss worldwide, mainly also because of backing from industries as well as a lot of conferences, there will be the biological treatment. So medications, as we are more familiar with it. So in the mainstay of treatment for depression would be psychotropics, specifically the antidepressant class. Even though there are many more augmentation agents that are currently FDA approved for use in treating depression, so it's not just restricted to only antidepressants. We have also the newer atypical antipsychotics or partial agonist antipsychotics, as well as mood stabilizers, and also other modalities such as the anti-NMDA and NMDA receptor antagonists that are currently approved in the treatment of depression. So basically, there are over 20 types of approved medications in the market that is clinically effective in managing depression. And there are a lot of robust clinical guidelines being published in the use of these medications, be it from the Americans, the British, as well as the leading European organizations of healthcare. And I'm just going to illustrate it very simply in this meta-analysis actually done in 2018, published in the Lancet by Cipriani and his colleagues. So they look at the comparative efficacy of 21 antidepressants in the market, and majority of them is available in Malaysia as well, right here. And basically the conclusion is that all antidepressant works. It's just a matter of finding the right medication for your patient profile and finding the right combination where you need to balance between efficacy and tolerability right here. So essentially, we are not in a dire, I would say, in a dire need of finding new medications. But on the other hand, what happens when medications alone are not enough to manage the depressive symptoms? So this is where the next step comes in, and we will talk about psychological interventions. One of it, for the topic of discussion today, would be psychotherapy. It's actually very well described in literature to be effective, and it's even recommended in clinical practice guidelines to be one of the mainstays of treatment in managing depression, even in the Malaysian guidelines. But however, psychotherapy as a whole does not seem to be a very well publicized or discussed subject matter, as well as their chemical counterparts, partly because of the perceived ceiling of entrance or access to it, and also because of not much of empirical data supporting psychotherapy. It's a bit difficult to measure effectiveness of talking to a therapist or giving it a rating, and it also depends on individual to individual responses. So I can understand that's why psychotherapy doesn't seem to be in the spotlight as much. Just a little excerpt here. I just want to highlight to you psychotherapy's appearance even in our local Malaysian guidelines. So this is taken from the Management of Major Depressive Disorder, second edition, from the Ministry of Health Malaysia Clinical Practice Guidelines, recently published, not too recently, but in 2019, so about 5 to 6 years ago. And you can see that from their algorithm, so in mild to moderate depression, psychotherapy is actually one of the recommended treatment modalities available to the patients, as highlighted in the red boxes there. And in fact, in mild depression, psychotherapy ranks before pharmacotherapy, as you can see in the first line right here. So patients should always be considered to be embarking on a brief psychotherapy treatment, I would say, duration, before we can definitively say that, look, let's go and talk about medications. So this is something that we should explore here, and just to remind everyone about this. So let's jump in and discuss psychotherapy. Is it a session that just involves us sitting at the therapist's couch and just talk about all our problems, and at the end of the day you pay a sum of money and then you see them the next month? Not exactly. So as you can see, in the background there's a couch, and actually that's not how we do psychotherapy these days. The psychotherapy landscape has somewhat evolved. I attended a conference by Professor Alfonso last year on psychodynamic therapy, and he also mentioned that his office layout, he used to have a traditional couch like that, but because he finds that it's a treatment session, so patients come in for therapeutic, I would say, outcomes. So he has also modified the modern psychotherapy setting into something like akin like a clinical setting that we see in our clinics right here. So the patient comes in, we sit near the desk, have a conversation with the doctor, treatment ongoing, treatment goes on, and then subsequently they are discharged as per any other patients and they return for the next session. So it feels like a very genuine clinical encounter. And that's the paradigm shift for therapy these days. So I'd just like to highlight a very beautiful article written by this group of researchers from Europe, and they actually look into psychological treatment of depression over the years, and they did a systematic review via what they call a meta-analytic research domain. So MARD or MARD is something quite novel, in which they actually developed it to look into effectiveness of many clinical trials, also RCTs, looking into psychotherapies for depression. And they look at data that cannot be covered by just simple network meta-analysis or network meta-analysis. And these MARD that they come up with actually allows them to come up with a very encompassing results to discuss about the effectiveness of psychological treatment for depression. Well, I think it's an 11-page article. You don't have to read everything about it. I shall summarize it for you in the next few slides, and let's dive into it. So first introduction, what exactly is psychotherapy? It's actually not as obscure as we think it is. It's actually structured, evidence-based psychological intervention that is tried and proven and tested based on sound principles of psychology as we know it over the past, I would say, 1 century. It helps us modify behaviors, thoughts, and emotions of the patient or the client. And typically, it is delivered by trained professionals through various formats and also settings. So by trained professionals, I'm talking about certified clinicians, could be a psychiatrist, could be a clinical psychologist, could also be a counselor. And what are the modalities of psychotherapies available for depression? So this slide is not an all-encompassing, I would say, slide that covers all psychotherapeutic modules, but these are the common ones. And the article particularly highlighted these 4. So we have therapy modalities such as CBT or cognitive behavior therapy, interpersonal therapy or IPT, behavior activation therapy or BA, and also last but not least, we also have psychodynamic type therapy. So why did the article single out these 4 modalities for discussion in treatment for depression? It is because of the robustness of the evidence that they managed to gather in the RCTs that they analyzed. So they analyzed a total of 118 RCTs, and they find that these 4, I would say, modalities of treatment are the ones that crop up very, very frequently and also well studied. So CBT addresses the negative thought patterns that the patient has, and through it, from addressing the negative thought patterns, we want to enhance better behavior and also better, I would say, cognitive outcomes. Interpersonal therapy allows the therapist and the client to work on relationship dynamics. So if relationship issues is one of the precipitant or also the perpetuating issues causing the client to be depressed, that would be a very useful modality to address. Behavioral activation allows the therapist to encourage the client to engage in activities that they somehow were able to accomplish at ease when they're not depressed. But when they are in the throes of depression, people tend to find it to be very difficult to have the initiative to do something that they used to enjoy. Behavioral therapy activation is one of the steps that we can get them to get started again. And last but not least, psychodynamic therapy allows the client with very particular, I'd say, traumatic or very deep attachment issues to explore their past experiences and to work on resolving those issues and to prevent subsequent worsening of their depression. So it empowers them to move forward with a different perspective in life. And all 4 domains show comparable effectiveness in treating depression. The matter is that not one patient needs to undergo all 4. It's a matter of choosing what's most suitable for your patient at the time being. So how effective is psychotherapy in general? Well, this article looked at 118, but in essence, there are about 850 plus randomized controlled trials in the past 20 years. And we look into it, the average effect size is about 0.6 to 0.8 on the Hedges G. So there is moderate to effective efficacy right there going on. So it's definitely not placebo. So it works across different populations and formats. So it could be populations from different areas of the world, different age groups, different pre-morbid medical needs. It can work via delivery in individual versus a group format. It can also work via delivery by phone call or teleconsultation. Even now, after the pandemic, they move towards the online delivery method as well. And in fact, a fun fact here, or interesting fact here would be that psychotherapy is actually more effective than antidepressants in the long term in some studies that's highlighted in this article. Definitely better than no treatment or standard care, in which basically just seeing a doctor, refilling a prescription, and coming back the next month for the new prescription. And people who are on psychotherapy, because they learn new skills and because they're a bit more resilient and more flexible than their non-psychotherapy counterpart, they seem to have lower relapse rates compared to just being treated on pharmacology alone or medications alone. So there is robust evidence favoring having psychotherapy as part of the arsenal of the psychiatrist or the psychologist right here. Now, if you look at head-to-head comparison between psychotherapy and its closest treatment modality or treatment competitor, which is antidepressants, they both have similar short-term effectiveness. But like I mentioned earlier, long-term psychotherapy offers better relapse prevention, so less chances of the patient having a recurrent episode. Combination therapy of both, why not have both pieces of the cake and eat it? So therapy plus medication is obviously the most effective because there's a compounding effect. And the response rate for therapy is approximately 50%, about 41%. So basically 1 in 2 patients will respond to therapy. Whereas, compared to just usual care, as in just prescribing a medication and seeing a doctor, so there's actually a less than 20% compliance rate on your patients to be happy to just take medications alone. And is also a suitable alternative for patients who always prefer the non-medicative approaches from the get-go. So let's go back to that CPG slide that I showed you earlier. It's also indicated for mild and moderate depression. Remember, psychotherapy comes before pharmacological intervention. So this is a good approach for us to get our patients to be more willing to seek help for their psychiatric ailments. But is it for everyone though? So let's just look at how is it delivered, then we answer that question. So as I mentioned earlier, psychotherapy can be delivered via different modalities and different approaches. So we have the individual therapy, which is what we are more familiar with, and stereotypically is that one-to-one with your therapist in a room, lying on the couch, and we talk about your problems. So individual therapy is also one of the most, I would say, prescribed and most administered form of psychotherapy. Is still a one-to-one session, mainly because number one, we want to respect the patient's autonomy and also their confidentiality. So there are things that they're not comfortable to confide beyond the walls of the clinic setting. Individual therapy is still the way to go. There's also group therapy, in which we encompasses more of a peer support kind of approach. And when patients talk about their shared experiences, so for example, there'll be a group CBT to talk about how each of them have different cognition or core beliefs that they wish to address as a group. It's led by a therapist, but the patients themselves contribute most to the discussion. Then there's also telephone-based therapy overseas. So it's effective and very accessible. You don't necessarily need to physically come to the office and get a therapy session. But there will be, of course, legal implications in place. So there need to be safeguards to safeguard both the therapist as well as the client. And there need to be very robust gatekeeping mechanisms in case there's a risk assessment needs to be continuously ongoing. And if the client is at risk of hurting themselves or others, the therapist has I would say, protocol, or I would say guideline to address that effectively. And last but not least, there'll be something what we call guided self-help, where psychotherapy can be delivered as a whole, individually, at the client's own pace via modules that's already prescribed. So these can be offered either as online psychotherapy modules or structured programs with professional support, where they do the homework they come in, and it's basically self-directed with chapters and I would say prescribed homework for them to compare notes to, and there'll be a logbook for them to fill at the end of the day. So psychotherapy is quite flexible. Psychotherapy is also quite applicable to every individual with different needs. Of course, there should be special considerations for populations of note, such as children and adolescents. Maybe there's slightly smaller treatment effects among children and adolescents, and they often require a bit more involvement from their family members, such as parents or closest next of kin. Particularly is because sometimes maybe children are not so neurodevelopmentally mature, so a lot of the concepts that we try to teach them in psychotherapy, they may need a bit more guidance and then meet an adult with them to help them go through the whole modules. It doesn't mean it doesn't work, we just need to maybe tailor it to the population of children. As well as older adults, we're talking about a geriatric population. As our age curve in worldwide moves towards the older geriatric onset, so we're dealing more and more people with geriatric psychiatric problems. It's equally effective, but it's often underutilized with the core belief that we think that just because it's difficult to teach an old dog new tricks, it means that people are just more willing to try it. But it's actually as effective as psychotherapy in younger adults. And older people can be quite flexible and resilient in terms of learning new skills as well. So it's not something to be slipped at. It's also an additional benefit because psychotherapy does not involve adding a new medication to the battery of medications that typical older adults has already been taking. Because premorbidly, they could have a lot of non-communicable diseases that requires active pharmaco intervention. We would not want to necessarily add on to that burden and cause more drug-drug interaction. So we can always consider psychotherapy for older adults. What about patients with chronic depression? As we understood, depression itself can be a debilitating, very disabling condition that lasts long into a person's, I would say, lifespan. So sometimes in chronic depression, medications alone does not seem to yield effective, I would say, treatment outcome. So combination treatment with psychotherapy may yield better outcomes for these patients as we teach them more resilient problem-solving skills, more resilient, I would say, alternative thought patterns to counter their negative core beliefs. This could be a way to help them improve further in terms of their depression treatment. And last but not least, we come to the population of patients with comorbid conditions. So this falls under the domain of a multidisciplinary management of patients. So these are patients that have depression with secondary conditions. It could be an existing psychiatric issue such as depression with anxiety, or a patient with a chronic medical debilitating condition such as cancer, or also incurable diseases or autoimmune diseases such as lupus, and so on and so forth. So patients with an additional disease burden, they are more at risk of developing depression as it is. Treating them with the conventional antidepressants might interfere with their existing medications. So psychotherapy could be a good alternative to add on to that, I would say, arsenal of treatment that we can offer these patients. Right. So what are the impacts of psychotherapy? Like we know that it can be delivered. We know it might work for different populations. So what we exactly hope to see here? Well, improvement of quality in life and social functioning. Back to the first point there, we want to reduce the disability and also the morbidity. It reduces a lot of anxiety and stress-related symptoms in the sense of depression because in psychotherapy, we teach them problem-solving skills. We also teach them a lot of counter thoughts to their negative core beliefs. So this will reduce anxiety and stress. It can positively impact their physical health because of behavior activation. So we might get the patient to actually live a more, I would say, healthy lifestyle. We might effect therapeutic lifestyle changes. And also in terms of chronic disease management, it allows them to be a bit more aware of what's happening to their own physical body and also about their psychological well-being, allows them to be more attuned towards their treatment plan. And it also improves adherence to pharmacotherapy by building the insight on the patient. And it helps them with maintaining to be on track of treatment as prescribed by the doctors. So it reduces a lot of therapist, client, I would say, frustrations in the long term. So now talk about common myths on psychotherapy. So does it take too long? Typically, we need to see the doctor for years and years and years. There seems to be minimal improvement. No, but actually, looking at the paper and the evidence that we have, even short-term therapy is effective. So it could be a 6 to 12 session brief psychotherapy, and it's enough to effect positive change in the client. Well, what about, is it as expensive? Like, do I need to spend hundreds and hundreds of dollars or hundreds and hundreds of ringgit every time to see a therapist? Actually, there are many affordable options available out there. And as in recent changes in the insurance scheme and also insurance industry, they're also encompassing psychological interventions as part of the coverage. So your clients can also look into options that are subsidized. And in Malaysia, in most mental health services in the public setting, there are counselors and so therapists and so psychologists under their employment. The patients can still access them under our universal healthcare package. And is therapy only for severe cases? No, as we demonstrated earlier, back even quoting the clinical practice guidelines, it is beneficial across all severity of depression, so mild, moderate, and severe. In fact, in mild depression is the first line recommended treatment before medications. So what's next in psychotherapy? We talk about the conventional psychotherapy, the one-to-one, seeing the doctor in the office, sometimes being offered via phone calls. So as we progress, even like this meeting, for example, we are doing is online. So digital therapy is something that we can look into. I understand that there are modules of internet-based CBT being available in the US right now, and we should look into that model and maybe expanding such access to our shores right here soon. There's also task sharing approaches. So in Singapore, I think what they are doing there is to lower the glass ceiling of treatment accessibility and also training to therapy to people who are non-psychiatric related. So training non-specialists to deliver the core steps of therapy or the initiating steps of therapy is quite effective. So what I understand in Singapore, social workers are equipped with basic therapy skills that can engage the client initially, get them on board before referring to the psychological services. That's a good, I would say, gate opening measure. And last but not least, psychotherapy, like medicine, is moving towards personalized therapy. So it's based on the client themselves, and we tailor the treatment approach to the client. So it doesn't need to be a prescribed CBT that you just continue dialectical modules prescribed to you. We can mix and match different modalities and different principles, and we help the client following the needs as they evolve in the therapy sessions. So we should make psychotherapy accessible, and we should do our part in lowering the perceived ceiling of access. So as healthcare staff, for starters, we can start by recognizing symptoms of patients struggling mentally or psychiatrically, and we encourage them to discuss about it. So talking about it is the first step of psychotherapy typically, and psychoeducation oftentimes is the most effective way to initiate the discussion of therapy. So we should provide accurate information to the patients so that they can make an informed decision whether they want to embark on therapy or not. Reduction of stigma by normalizing mental health care. If everybody doesn't talk about it, it's not a problem. But if everybody starts to talk about it, then maybe it's not so taboo a subject to open up in society. And last but not least, refer and collaborate with your mental health professionals. We are always very accessible, and I think we are not strangers towards accepting referrals from our colleagues, and we are more than happy to have them seen in our setting as well. So some practical considerations: identify patients of yours who may benefit from psychotherapy, particularly those who struggle with medications or who struggle with the stigma of wanting to accept that they are needing psychological help. We encourage them because of the long-term benefits. There should be access barriers that we need to be aware of. In our hospital setting, things are a bit easier here, but I can understand if you're living in the non-urban setting, there may be the concern of cost, there may be a concern of availability. But like I mentioned earlier, as long as within the Malaysian public healthcare system, there are psychotherapy and also psychologists and also therapists available to the patient in each tertiary center statewide. You should also refer patients to the mental health services when you think it's indicated. You don't have to wait until the symptoms are too late before they come and see us. Oftentimes, intervening early ensures, I would say, effective outcome and also less disease burden plus less medication burden as well. So to sum up, psychotherapy, as we say, is effective and flexible. In depression, there'll be no major differences in effectiveness with medication and therapy. It works well across all populations, but long-term engagement is key to see the long-term effect of psychotherapy. There should be support that we give the patients in accessing the appropriate care. And with that, I think I end my discussion by encouraging you to come and see us in the department if you think you have patients or you yourself will want to come and have a chat with us. We are located at the ground floor of the psychological medication complex next to dental, and we are available for outpatient clinic consultation as well as inpatient referrals in this hospital. With that, thank you, and I pass it back to Dr. Manveen.
All right. Thank you, Dr. Julian. That was an excellent presentation. We've got a couple of questions, but we're a little bit short on time, so we'll just make it a little bit quick, yeah? All right, so that would be, all right. Does our department have does our department do telepsychotherapy? And does teleconsultation using psychotherapy work with this group?
Thank you for that question. Unfortunately, we have yet to embark on offering telepsychotherapy in this department, mainly due to some, I would say, legal as well as medical legal and as well as ethical issues that we need to iron out in the first place. We need to first safeguard our patients' safety if we are embarking on a therapy session via teleconferencing. What is there to do with risk mitigation? What about suicidality? What about risk of harm to others? So until we work that out and there's a good framework for us to safely deliver that modality, we are still limiting our sessions in PPOM to face-to-face sessions right now. But it is effective. It's being done internationally, and this is something that we need to explore with legal as well as our existing framework of support.
Yes. Does teleconsultation using psychotherapy work with groups?
So from what I understood, teleconsultation for groups actually works because a lot of the clients find it very difficult to accommodate their schedules, and sometimes having a virtual platform allows them to access therapy from wherever they are. I would say still go back down to risk assessment. If the clients are identified to be low risk and effective communication can be effected by online engagement, yes, it's a viable option. Only in our hospital, we are limited by the, I would say, infrastructure and legal framework right now. But it's being done. Yes, I think we should look into it.
All right. One more question, a last question. What are your thoughts about third wave psychotherapies for depression?
Okay. So we talk about third wave psychotherapies. There are things like acceptance and commitment therapy. They are been coming. These are all effective, and they actually go back towards applying very core principles that have been tried and tested over the years, and they just evolved to suit the modern client population. And these are actually quite viable options for, depends on the clients that you have, and maybe some of them would rather embark on third wave therapy modalities. There's no right or wrong answer. If it works for them, I would definitely encourage them to explore.
All right. I think we've run out of time now. I think there's some more questions coming in. Yeah. And perhaps we could answer it another way then.
Yep.
Yeah?
I think I'll type the answers in the chat box. So thank you everyone for your time.
Yes, thank you for your kind attention, and have a great day ahead. Thank you.